Welcome to the Patient Joint Replacement Education class. My name is Jonathan Shaw. I'm here to educate you a little bit about your procedure before you undergo either your total knee arthroplasty, your partial knee arthroplasty, or your total hip arthroplasty. The class objectives will be to understand why and how this surgery is performed. You're going to understand the typical hospital course, as well as the typical recovery after such procedure. Most importantly, we're going to talk about and discuss the possible complications that come from this surgery, as well as what the surgical team, as well as you, can do to prevent these possible complications.
Let us talk a little bit about the knee anatomy. When it comes to the makeup of the knee, it's made up of 4 different bones, 3 of which are involved within the procedure that we do in a knee replacement. One is the femur or the thigh bone. One is tibia, which is the shin bone, and one is the patella, which is the kneecap that sits in front of the knee. Cartilage surrounds all parts of the knee joint, which allows it to move smoothly. There are 4 important ligaments that we consider during a knee replacement: the anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament, and the lateral collateral ligament.
Arthritis is defined as inflammation within that knee joint and then the subsequent destruction of cartilage tissue. This is what we define as bone-on-bone arthritis or end-stage arthritis. There are different types of arthritis, including primary osteoarthritis that occurs with your normal wear and tear of your knee as we age, as well as a genetic factor. There are different types of arthritis, including rheumatoid arthritis and post-traumatic arthritis. The knee itself is comprised of 3 different compartments. There's the medial compartment, or the inside part of your knee, the lateral compartment, which is located on the outside of the knee, and the patellofemoral compartment, which is the compartment that composes the kneecap. Patients can get arthritis in all 3 compartments. They can get it in 2, or they can get it in 1, and the treatment can be different based on the location of your arthritis.
The surgical treatment for arthritis is twofold. When it comes to partial knee replacement, this is indicated for patients who have arthritis only in one compartment of their knee. At this point, then, the replacement surgery is to replace only the area of the knee that has the arthritis itself. There are several different popular implant companies that create partial knee replacements. We talked before that partial knee replacements are good surgeries for faster recovery, better range of motion, as well as a more natural feeling knee.
However, when multiple compartments of the knee are arthritic, a total knee replacement or total knee arthroplasty is indicated for that patient. In a total knee replacement, we resurface all of the damaged cartilage from the knee, and then we replace it with implants. Those implants are attached to the thigh bone as well as the shin bone. In between the metal implants are a piece of plastic called polyethylene. This allows for those implants to articulate smoothly. Total knee replacements' primary goal is to relieve that patient's pain, but it also will give that patient a straighter leg postoperatively. Going over the hip anatomy now, the hip joint is comprised of a ball and socket joint. The ball itself is attached to the femur or the thigh bone, and the socket, which is the acetabulum, is attached to the patient's pelvis. This joint is also comprised of cartilage, which allows that joint to move smoothly and without pain. However, when arthritis is afflicted in the hip joint, again, this is an inflammatory response which causes subsequent destruction of the cartilage tissue. Again, patients then get bone-on-bone arthritis, which can be painful. The pain most people feel from hip arthritis occurs in the groin area, but also can refer to the anterior thigh, as well as cause different types of inflammation like trochanteric bursitis. There are different types of arthritis, including primary osteoarthritis, again, normal wear and tear of the joint as well as a genetic factor, rheumatoid arthritis, post-traumatic arthritis, but also two very specific types of arthritis called avascular necrosis, when the blood supply of the hip has been cut off due to injury or disease, or congenital deformities like hip dysplasia, which then can give patients arthritis early on in life. The primary surgical treatment for hip arthritis is a total hip arthroplasty or total hip replacement. Similar to the knee, what we do is we replace the hip joint with metal, plastic, and ceramic in order to help create a smooth articulating surface in order to reduce pain as well as improve patient's function. There are different types of implants that can be used during a hip replacement, some that grow into the bone and some that are cemented in based on the patient's bone health. Through my training, I'm able to specialize in minimally invasive joint surgery. This means that I minimize the amount of muscle, tendon, and ligament that is cut during the procedure. There are several benefits that help patients during their recovery period, including less postoperative pain, a faster rehabilitation, as well as a smaller incision and scar.
After the surgery, your incision is going to be dressed with what's called an Aquacel. This is a waterproof dressing that allows you to shower right after the joint replacement. It also has an antimicrobial property in order to reduce the chance of infection. You will also be purchasing a second Aquacel, which then you put on post-op day 7 after you remove the old one. This allows you to shower for 14 straight days after your surgery. If you do not purchase one of the Aquacels post-operatively, then I ask that you don't shower after that post-op day 7 when you remove the original bandage. Some patients are going to go home with incisional vacs. These are special pressure dressings that allow them and their comorbidities to improve their wound healing and incision healing. This is also waterproof. However, I ask that you don't shower with this bandage. I do say that after 7 days, you will remove the suction dressing and then you will replace that with the purchased Aquacel afterwards. Many of my revision surgeries will go home with a Prevena in order to help bring blood supply to the incision and improve healing. Here is the post-surgical dressing incision care. You're going to be removing it 7 days after your surgery. Simply peel it off like a Band-Aid. After you remove the original dressing, you will put a second Aquacel on for an additional 7 days, which allows you again to shower with it. You will be going home with some kind of compression wrapping, either that being a thigh-high compression sock or an ACE wrap. This will help with postoperative swelling. However, do not use this while you're taking a shower. Please remove that compressive dressing afterwards, before the showering.
When it comes to anesthesia during your procedure, we have made many advances in order to make it safer for patients. At this point, we rarely use general anesthesia, which allows for patients to have rapid recovery. Instead, we use a combination of spinal and regional anesthesia. Not only will this reduce pain during the procedure, but it also reduce pain after the procedure, allowing the patient to be able to get up, move, as well as rehab immediately after their procedure. We ask patients to stay well hydrated 3 days prior to their surgery by either increasing their water intake or adding a carbohydrate type drink before the surgery. In fact, we ask them to take a Gatorade 2 hours prior to their scheduled arrival time to the hospital. Patients can also take whatever day of surgery oral medications they are instructed to take at that time with the Gatorade.
I also recommend that all of my patients purchase chlorhexidine wipes before their surgery. These are to be used the night before surgery as well as in the morning before the operation. You use these wipes to clear off the skin in order to reduce the bacterial load before operating. This helps with reduction of postoperative infection rates. I don't recommend using these after the procedure, especially during your recovery period. When it comes to the hospital and surgical center course, what you will have is a preoperative telephone call from the nurse at the hospital. They will not only give you the time of surgery, when to arrive, but also when to stop eating and drinking. The day of surgery, you're going to arrive at one of 4 of the places that we have recommended for you. You will be in the preoperative holding about 90 minutes to 2 hours before your surgery. That allows for the anesthesia team to evaluate you and get you ready for surgery.
Once you are prepared for surgery, you will arrive in the operating room. In the operating room, you will be there for about an hour and a half to 2 hours. This allows the surgical team to position you. The procedure itself takes about 30 to 45 minutes. And then incision closure and reversal of the anesthesia takes the additional time. You then will go to the recovery room for about 1 to 2 hours. And if you are leaving the hospital that day or outpatient surgery, then you will go home from the recovery room, or you will arrive on the orthopedic floor for 23-hour stay.
The lines, tubes, and drains that will be given to you while you're in the surgery and while you're in the hospital is a simple peripheral IV that allows anesthesia to appropriately monitor you and give you medication, as well as these sequential compression devices that allow increased blood flow through your legs.
Discharge requirements entail 3 separate categories: physical therapy, medical stability, and pain management. Once all 3 have been passed, the patient is deemed appropriate for discharge. The type of physical therapy will be based on where the patient is being discharged, as well as their medical and pain management will be based on the patient's reaction after the surgery.
We provide cold therapy after our surgeries. When it comes to knees, we provide a cryo knee, which allows patients to go home with a device that will provide cold therapy around their knee as well as around the incision that reduces swelling as well as reduces pain around that knee. For hips, you will have an option to purchase an ice machine like a Playmaker. However, if that is an out-of-pocket expense that patients worry about, then simply a bag of ice around the hip incision will help. We recommend that cold therapy be used 4 to 5 times a day for about 20 minutes, but it should never inhibit a patient's ability to participate in physical therapy and range of motion exercises. These are the typical postoperative pain management medications you will get. Most patients are going to be going home with these types of medications. This is what we call a multimodal pain regimen, which has been proven to reduce opioid use afterwards and reduce pain after your surgery. Therefore, we will give you a sheet in your preoperative visit in order to go over exactly what these medications are, the quantity you will be taking, and how long you should be taking them for. Other medications include our blood clot prevention, like aspirin twice a day. However, those that are on blood thinning medications, we will talk and discuss with you what you will be taking after the surgery. When it comes to stool softeners, it's very important to take these post-operatively if you're continuing to take your narcotic medication. Narcotic medication causes constipation, and so to offset that effect, we give you a stool softener. For those that have high risks of post-operative infection due to medical comorbidities, we will be sending people home on oral antibiotics. The nausea medication won't be sent home. However, if you do have quite a bit of post-operative nausea, you can call in order to ask for an anti-nausea medication. Physical therapy and home therapy is provided to patients as long as it can be pre-approved by their insurance pre-operatively. Some insurances do not approve that, and we will accommodate you to get you to your outpatient physical therapy as soon as possible. If you do have home therapy, they will come post-op day 1, and we will get you up and moving in order to help teach you the exercises you need. The exercises you learn post-operatively in the hospital will be the exercises you will do in week 1 after your surgery. We will start outpatient physical therapy either week 1 or week 2 after your surgery.
These will be your follow-up appointments after your surgery. We will want to see you back 2 weeks post-operatively. This allows me to look at your incision as well as get x-rays of the procedure. We will also see you back 6 weeks post-op. Again, we will look at the x-rays, and then 3 months post-op, and then annual visits afterwards. This allows us to closely monitor our patients' progress in order to optimize their recovery after their surgery. You will see me at each one of these post-op visits. There are some frequently asked questions from patients after their replacement surgery. One is, when can you return to work? If you're light duty, a desk job, or work from home, I've seen patients go back after 2 days of recovery. I recommend you taking about 2 to 4 weeks post-op in order to focus on your recovery, but I leave that up to the patient. When it comes to laborers or heavy-duty work, then I ask that you take about 6 to 8 weeks post-op in order to recover fully, in order it to be safe for you to go back to work. When it comes to driving post-operatively, you can drive once you feel safe and once you are off all opioid medications. However, they do say around 2 weeks post-op is when your reflexes are back in order to brake safely. When it comes to flying, research has shown that it is safe to fly even 1 day after the surgery. Therefore, those that are coming from out of town or those that travel frequently can start flying the day after, but will have to take accommodations in order to help them so that they can get through the airport. When can you return to exercise? This is similar to the heavy duty or labor type work. I ask that you give yourself at least 6 weeks in order to ease into those activities and exercises. When can you have your other side replaced? Usually, I make patients wait 6 weeks before their surgery. That means that you're about 80% recovered on the other side, and therefore you can have a good side to recover on. Most people are taking this time, and about 3 months after their first replacement, they go in and take their they do their other replacement surgery. Let us now talk about potential risks and complications of hip and knee replacement. Although these percentages are low when it comes to these types of risks and complications, they vary among patients based on their comorbidities. The number one complication in arthroplasty is infection. That is why it is paramount for people to be medically optimized from their comorbidities, stop smoking, and then I and my team do specific things in order to reduce those risks, like the chlorhexidine wipes preoperatively, the IV antibiotics I give to the patients before the procedure, as well as shortening that patient's hospital stay as much as possible so that the patient's risk of infection has been reduced. The other major risks would be a blood clot, which is also known as a DVT or PE. We give each patient anticoagulation medication or blood thinning medication after the procedure for 1 month. But the key to reducing that risk is early mobilization of the patient. Therefore, I ask that you continually get up and move after your procedure. Another risk is a hematoma that can occur after the procedure, which is blood collection within the joint or blood collection within the soft tissues. Surgical compression can reduce the risk of hematoma, which is why we provide ACE wraps or compression socks for our patients. Here are a list of other potential risks and complications. Dislocation is when the implants do not articulate together. Most of the time, this is from a fall, or if patients are given precautions, they are not met postoperatively. Loosening and failure of implants can be a long-term complication. However, with the modern implants, this complication has become very low, and I do not restrict patients from doing the activities that they enjoy. However, it is still a mechanical joint, which means that the more we use the hip or knee replacement, the more likely it can wear out. Residual pain and stiffness can occur after their arthroplasty. The goal is to reduce the pain. It may not take it completely away. Stiffness occurs when someone is stiff preoperatively and then can have a higher risk of stiffness postoperatively. There are times where patients have a tendency to scar more than others. Those have a high risk of stiffness and can cause the articulation and range of motion of that joint to be reduced. Fracture is a risk. That's why we want you to be cautious postoperatively. Using a walker, and then when feeling comfortable, a cane, and then when feeling comfortable, no ambulatory aid, will reduce the chance of the patient falling. Nerve injury is always a risk during the procedure. The knee and the hip are near different nerves that span the lower extremity. When those nerves get irritated, they can react and cause nerve injury. This is a very, very low risk when it comes to these types of surgery. However, it is a risk that patients should understand. Blood loss and vascular injury can occur during the procedure. We do several different intraoperative steps in order to greatly reduce the blood loss of these procedures. And this keeps these procedures safe for patients, even patients who are being discharged home that day. Skin tears, blisters, and delayed wound healing can occur. Some have reactions to bandages. Some have delayed wound healing because of comorbidities. I see patients and track them very closely postoperatively in order to make sure that they have their best recovery possible. The clicking of the arthroplasty, either in the hip or the knee, can be a common concern of patients. Yes, this is a mechanical joint, and therefore clicking can occur. As time goes on, that clicking becomes less noticeable. The clicking is not damaging the implant or causing it to wear out sooner. Therefore, even if you have clicking after your procedure, you have no restrictions on activities. Leg length discrepancy, especially in hips, but also can occur in knee, can occur because patients notice a difference in their leg length. Most of the time, this is because they had shortening of their leg length due to their arthritis. And then when the replacement occurs, it quickly changes their leg lengths back to normal. The leg length discrepancy, like clicking, can become less noticeable as time goes on. You will work with physical therapy to strengthen the muscles around the hip and knee, which will allow you to walk appropriately. Insomnia is a risk. However, when it comes to insomnia, that improves postoperatively. Some patients get affected by the anesthesia or the medications we give them postoperatively, which then allows them to lose sleep throughout the night. However, as the medications are removed during the recovery period, the patient has less insomnia.
Symptoms after a surgery that are common occur in almost every patient, especially after a joint replacement surgery. The most common is swelling and bruising throughout the leg. Most of that swelling and bruising does go downstream from that surgery. That means that patients' ankles can swell, patients' calves can swell, patients can get bruising in their feet after their surgery. This is a normal process. That swelling improves with elevation, compression, and icing. The warmth around the knee as well as the hip after an arthroplasty is normal. That is the normal healing process from the body after the surgery. Incision redness is from the normal trauma that occurs during the surgery, as well as the swelling that occurs. That will improve as time goes on. A low-grade temperature can always be normal, especially immediately post-operatively. That's from the anesthesia effect and the trauma after the surgery. When should you call? If that swelling, calf pain, and redness does not improve with elevation, compression, and time. If that fever gets over a 101.5 and is increasingly staying the same even with Tylenol, then the patient should call. If you have significant drainage through the incision, then please contact the office. Pain that is uncontrolled by all of the medications that you are given postoperatively, a patient should call, as well as redness that started by the incision and is starting to spread throughout the leg, please call. How should a patient prepare for surgery? The most important thing a patient should do is read through all of the paperwork that was given to them in their office visits with me. Also, make sure to stop the medications that your internist instructed you or your primary care instructed you before that. There is a sheet with specific medications that have to be stopped on a certain date before their surgery, or their surgery will be canceled. So please read through that. Prepare for living arrangements as necessary. You will need someone to help at home for the first few days. That can be a friend, it can be a church colleague, it can be a family member. But I do ask that someone comes around your house post-operatively in order to check on you. Wash that surgical area with those antimicrobial wipes. And then also relax. Joint replacement surgery today is a very common procedure. People do very well. It does take some recovery. However, once patients are recovered, they can go back to a quality of life that they expect. Know that you're in good hands. Thank you. please reach out or talk to me during your preoperative clinic visit, and we can go over any further questions and concerns you may have.